Sure. So I think that this consensus is important to follow, and this consensus has been done for give a street to follow together to perform the exam in the same way, and all the group in the world have to follow the same guidelines, and this was the needs that we I don't sorry the need that of the first annual meeting, and so we decided to do a consensus for this.
For ensuring a comparable accuracy, because one of the problem we had is the big variance among laboratories. So there was some papers showing no CCSVI at all, for example, by ultrasounds, and other paper showing important association from 60 to almost 100%. So this discrepancy, we thought probably is the fruit of different protocols, lack of consensus about the methodology to use. So the effort of the society was to have this consensus that has been published quite recently in 2 major journals. And the feeling of the workshop was to adopt this, but also to work in the next years to improve again the ultrasounds in this field. Especially many of the investigators suggested to perform more studies in normal people, more physiological data, because there is a lack of this data, to be compared with people with CCSVI, independently from MS or other neurodegenerative disorder that can be associated. Speaking just of CCSVI. And this found a complete agreement among the experts in the workshop yesterday. And also we had a specific program that are in course in different centers, like in Buffalo, University of Ferrara, and in London with Professor Nicolaides. So, and this may certainly provide us with data, and if the data should be good, probably we need of another one consensus to establish new protocols for improving our diagnosis and our accuracy.
Oh, thanks, Prof. You said basically everything. I agree with Professor Zamboni, of course, and this published paper was a product of a lot of work and time and brains put together of many, many experts from all around the world. And I think that the main thing after this consensus is that we all have a starting point to start measuring all the same things, and that afterwards the very important thing, we can compare results. Because this way we can have a larger number of subjects and patients, and I think we can be smarter after analyzing many thousands of numbers of patients than just every center doing the work for themselves. And also I think it's important that every now and then people meet and discuss the criteria and the consensus, and now we start working by these rules, and then we will see maybe something needs to be changed or modified, and then we can all together decide on these changes and again have a better product at the end.
I agree totally. I think our consensus brought together multiple centers, bringing each one an expertise in ultrasound. Different variables were used. This was brought out, so that's why the results through many centers were varying. With this consensus, we have sat down, modified and came up with a basis where all centers can use the same methodology in coming up with the result. They have to remember it's not just obtaining numbers. This ultrasound is actually a functional study, so they have to adapt to a functional study as to just gathering numbers. Also, each year we will revise because now every center will be collecting the same data. Just like Sandra said, we can therefore move on, move forward, simplify, and hopefully obtain the sonographers in the world will be able to train easier following these guidelines and produce the same results.
Okay. I'm going to ask a few questions, and whoever wants to answer can respond. You talked about basically setting guidelines. Can you talk a little bit about what some of the top-level guidelines are that you're hoping that all of the centers will adhere to going forward?
But this can be addressed really in this way. The original description of a criteria to be used for diagnosis of CCSVI was in a seminal paper, not devoted to technical details. So there was really a lacking of technical details to ensure the reproducibility of the Doppler system we proposed in our seminal paper. So the intention of the consensus was to bring together all the people very expert in ultrasounds in the world, currently working on CCSVI ultrasounds, diagnosis and screening, to listen to different proposals in order to try to reproduce the criteria in a very accurate way, and finally to vote and to have a consensus on what is currently the best technical way to be adopted in order to investigate properly the cerebral veins by the means of ultrasounds. So from one side there was a lacking of technical detail, and now we have a document very, very well detailed, in my opinion, that I agree with Karen and Sandra and Erica. This is really a starting point. But we really hope to improve.
And why ultrasound? Was that discussed of the three?
Karen?
Ultrasound's a non-invasive test, very safe, very simple, very easy. It's real time. You can actually see the vein pulsing, the changes with the breathing patterns, and this is all necessary to make a diagnosis. So, and it's cost efficient.
For instance, there is also other reason, because the issue of cerebral venous return is really complex, because there is a lot of mechanism that cannot be investigated properly, for example, with a different venography. Venography usually is an examination performed with the patient lying down with no respiratory system involved or change in posture or something like this. To the contrary, when we adopt ultrasounds, the patient or the subject under examination can be moved easily from supine to upright and to be invited to breathe, and so this gives a beautiful representation of the physiology in normal condition, of what really happened in a normal condition. For example, Dr. Menegatti showed a study in order to investigate the role of a thoracic pump. Would you explain this, for example?
Yes, of course. Now we are performing some physiologic tests, even through the ultrasound, because because we can investigate all the physiology law, and how these account into the cerebral venous return. So this method is useful for that, and now we are performing these studies, and we found a lot of new data for support also this consensus, because in the consensus comes up some questions unsolved.
I mean, what you are doing currently for investigating the respiratory system?
Yes, we use the ultrasound, and we use the ultrasound, and we elicit the thoracic pump action. So this is two functional maneuver, and so that the ultrasound can be investigate all this during the functional movement and the
So now we use a system where the subject breathes exactly a predefined quantity of air. This was because till now it was impossible to compare the respiration, the action of the respiratory system in subject with different capacity in the chest. So we set at 70% of the capacity of the individual capacity. In this way, we may explore the action of the respiration in normal subject in a comparable way. And this is very interesting because it's also non-invasive and may provide very, very useful data that are currently completely lacking. But this can be done just with ultrasounds, not with other methodology.
And you mentioned that you want to conduct more studies on normal people, and I assume that means people that aren't exhibiting any symptoms of CCSVI. What is your goal for that? I mean, do you have a particular number of patients that you want to reach, or number of study subjects that you're hoping to reach that you feel will be a good baseline for?
The first goal is that when we described CCSVI, we were aware just of the physiological mechanism. So we proposed a qualitative study that is really very operator dependent. There was a complete lacking of quantification in normal people of the blood coming out from the scalp to the heart. So now the goal is to have a physiologic basis in order to quantify the amount of blood flowing in normal condition or in change in response to posture and respiratory mechanism in normal people. The second step will be to quantify the same in the CCSVI population and to compare with normal. At that point, probably we were ready to start with a big study for quantification of cerebral venous return in different categories. Not just, I repeat, normal people and MS people, but certainly other neurodegenerative disorder will deserve further attention on behalf of the investigator of this society.
So will other neurovascular diseases that have any ties to Parkinson's and other diseases, will patients in those groups also be studied?
Yes, I think Karen Marr probably
Yes.
is doing a very good work in this field, Karen.
Yes. Our original CTVD study in Buffalo, we had patients which we call ONDs, other neurological diseases, which included Parkinson's, lupus, CVAs, cerebrovascular diseases, and some of these patients were also testing positive with a definite p-value which is relevant. So now we are moving forward and also including other neurological diseases in our study. Our phase 2 will come out, and we have included 100 patients, over 100 patients with other neurological diseases. So this will be interesting to find out. We've also included pediatric patients, CIS patients, which are considered clinically isolated syndrome. They are not definitely diagnosed with MS. They've had one symptom of an MS attack, but not definite diagnosis. We've included those patients also. All of these studies for the different categories of neurological diseases will help us to attain whether CCSVI is associated with those diseases as well as MS.
What are the most critical takeaways from the consensus?
Karen, what's good?
I think
we are discussing some points in a very useful way for everybody. Some proposal came from Karen, so she probably may explain some point of discussion that we are trying to improve between us.
Okay. I think the most important thing in the consensus is that there's so many groups from around the world here today, and they all want to find out what CCSVI is exactly, how to diagnose this, how to treat it, what diagnostic tools to use, how to perfect those diagnostic tools, and it's a collaborative agreement. Hopefully from this, at the workshops, everyone is in favor of having an international database. We have formed and are working on each for MRI, venography, IVUS, ultrasound. Those are the 4 main diagnostic tools. Every modality now has formed a consensus paper, and we will all be following those consensus papers on how to perform, what data to collect. When all this data, hopefully within 18 months, is collected from around the world, we can come up with a definite answer for people.
So 18 months, then really you won't be in a place in Krakow to have another consensus at that point? Or would you do it to use a baseline of where you are?
No, we don't think to be ready for the program that I outlined before. To be honest, I don't think that we have time enough. But probably we may have just a meeting in order to have a status of their heart regarding the different studies that are in course, and to eventually review the amount of physiological data to understand if this can constitute a solid base for comparison with a different category of our patients. This can be done at the next meeting.
And one thing that some of the other scientists and doctors have spoken about is the issue of how to begin to build some additional momentum behind this for those who are not yet part of ISNVD and already on the same page with what CCSVI is and the impacts that it has. So how can you take the information and the data that you're gathering as part of the studies you've done and that you're doing in the future and start to begin to create a more broad understanding and acceptance of this?
This is a very important point, because really there was 2 different behavior. A collaborative behavior, including groups very interested, and for example, they visited our center and tried to have a comparable training among the different investigators. This was very good. After this, they returned to work in their respective lab and produced data, and this was compared among center. This is a good way to face a new problem, because this never described before. So the other is to simply not to have any comparison, any exchange, and to perform immediately study with methodologies that are consistently different from the methodology proposed. For example, many groups performed the examination really at a very high level, for example, at the level of the neck, very high. And at that level, there is really different hemodynamics because major problems are at the base of the neck. So this really is a big difference in terms of results. But unfortunately, these results were published, and people like patients are very confounding by this kind of study, because certainly in a journal cannot be explained that there was different methodology and something very technical level. So they found 0%, and probably they are surprised and do not understand why. Really the problem is to try to have exchange, to be aware that this is a new field. We need to work together to be more collaborative and not negative or preconceptual study. Probably in this moment are useless, especially for the patient.
What else did I not ask that you feel is a point that must be made while I have you all here together?
I think research is a very important part of this process. I can understand why patients would want to just go and have the procedure, but we need to have these procedures done under controlled circumstances so we can move ahead. If we do not have the patients to do the research on, we're going to fail, because we won't have the people to prove to these other physicians, to the governments, to everyone that this is an actual disease that may be able to be solved. So we need the research to be done under controlled circumstances. And hopefully people will do this. Go to the research centers, please.
Dr. Morovic?
Yes, I agree with Karen on the patient's word, which I think is, it goes for everyone. It goes for us as researchers, for doctors, also for communication with other specialties. And it's a step-by-step thing. We have to really take it slowly and listen to other proposals, and also try to have them listen to us, and take it one step at a time and actually back it up with really objective studies and results. And I think this is the only way to go forward and to get acceptance from both patients and colleagues.
Dr. Zamboni?
It's perfect what Sandra outlined, perfect. Especially what are our wishes, because we always were very collaborative, and this is really an interdisciplinary work, because neurologist is certainly the cornerstone of the story for the patient. But this opens the possibility to cooperate and to offer our background from vascular diagnosis and eventually treatment under controlled study. This is very, very important, and also protective for the patient. And so we move forward in this direction, and over time we try to reach this goal.
Dr. Menegatti, do you want to add anything?
Oh, I think that all is already said. I agree with all of them, and I think that the research is important, and it is important also to maybe have a method for collect the data, and to also to share the data. Maybe a registry could be an idea for share the data coming from the center all over the world. And I agree again with Professor Zamboni to offer the vascular knowledge to the neurology knowledge for the benefit, move forward and the benefit of the patients.
Thank you all so much.
Thank you.
Appreciate you taking the time to talk to us.